All right, so as we work into chapter 2, I am looking through my email and realize I now have access to the exam. So I'm gonna make this really, really quick and really concise, and I am then going to jump into our exam, see what that looks like, start playing around with it, and start to prepare a lecture on that material as well. I still have chapter 3 to do, but I'm excited to be getting it this soon. So let's go ahead and jump into chapter 2, where we learn about legal, regulatory, ethical responsibilities, administration, paperwork. Oh my gosh. All right, guys, just listen, grin it, bear it, get a snack because I'm going to blow through this stuff as fast as I can. But oh boy, is it not going to matter because it's going to feel like I'm talking for 9,000 years because this is everyone's least favorite subject. So, dun dun dun, dun here we go. So, we're going to get into ethical responsibilities related to how things can get messed up. How do you make a med error? Oh, buddy, we're going to talk about it. I'm going to get into it. It happens all the time. Oh, no, that can't be right. You're nurses. Nurses know the answers to everything. No, nurses screw up all the time and at an alarmingly high rate, if I'm honest. So, for that reason alone, this is why I give you the dirt. This is why I give you the piping hot tea because you need to know the ugly truth of nursing because you are going to combat a fair amount of ridiculousness, of shenanigans with other nurses, and you have to create an environment within yourself that says everyone's going to respect me and everyone's going to respect the platform with which I keep and my moral compass with which I keep. And if they don't like it, then they can go. And you'll get there. When you do, it'll be really nice because you can kind of dictate the movement of the waves of the water, if that makes any sense. It's kind of nice because you can work with what you stand for and you don't have to feel uncomfortable for any reason. So, yeah, we'll talk about med errors. We'll talk about regulatory compliance and what that means, why we have to do things the way we do them, so on and so forth. So, let's go ahead and get into the ugly but factual truth of it all. All right, we're also going to talk about what the different types of drug orders are, what they look like, how we annotate those, what we need to do in order to make sure that they are double checked, things of that nature. And then we'll talk about our favorite topics, which are federal guidelines, state guidelines, and facility guidelines. All I hear is micromanage, micromanage, micromanage. But this is a necessary beast, friends. Nobody likes to be micromanaged. But the reason we are micromanaged is because there are clowns that make us have to be micromanaged. So these guys that sit in the ivory tower that I always make fun of are very, very important, as much as I don't like the idea of it, because someone's got to be the law, right? And if you don't want to be the law yourself, then the law is going to be handed to you and you're going to have to go under it. So pick a side, decide what you would rather do. I would rather be down on the ground fighting against it and losing miserably, but at least feeling, noble for it. But if you prefer to be on the other side, dude, there's a million and one places for you there too. So again, these are not my favorite topics. I don't know if you've noticed that. So we're going to blow through them as fast as we can because we need to know some of those things for testing material. But other than that, we're just going to hang out and talk about it real quick. All right, so federal laws and requirements. So the beauty of it is we have 3 types or categories of medications. So it's only 3 you got to worry about. One's controlled substance, one's prescription, one's over the counter. So controlled substances, they are pretty easily abused. They are incredibly dangerous. Why? Okay, listen, they're dangerous because they tell your brain that things aren't there, like pain. All right, why is this a problem? Well, when you think that you have no pain, and if you didn't take them, your pain would be excruciating, and it's meant to shut your brain off to say, hey, it's not there, I'm not here. And it's like the cloak of invisibility, like scope of Harry Potter. I'm sorry, that's cool and all, but if Harry Potter gets knocked down and punched in the face, and he's still wearing the cloak of invisibility. If you took it off of him, he'd just be on the ground. And that's what happens to your body when you get on these medications. And that's why it's such a big deal, because it's not the fact of the matter that it relieves the pain. It's not that, friends. That's not what it does. A lot of these medications literally shut the receptor off in your brain that says, ow, and it just goes clip and just shuts it off. So the problem with this versus, you just having relief of pain and you're still dealing with that pain is you take these meds and you keep getting them prescribed for years and years, and your brain does not develop any type of tolerance for anything because there's nothing that it feels. And then all of a sudden, the medication gets taken away and you were thriving. This is why it's such a big deal. This is why a lot of people in the 90s are really, really having a hard time now, because they are really cutting down on these medications. And these guys in the 90s were like, dude, you gave them to me then. And then they have to come off of them. And can you imagine, right? All those years of thinking you're doing what the doc says, and this is your reality. It's shut this idea of pain off, and now we've got nothing. So these are why we have controlled substances, because we have to control them, or we would effectively, still have the same problems we had back in the 90s. Listen, we got a whole lot of other problems, but, and I know that a lot of you guys don't think this, but if you were living in the 90s, effectively in the 90s, while people were prescribing things in the 90s, just trust me, I can attest, it is so much better now than it ever was. All right. And now we're kind of hopping to the other extreme where we're afraid to help people manage their pain by dosing them anything. So again, we're way to the left, then we go way to the right, and I'm hoping we get somewhere in the middle soon. Prescription, like require prescription, not easily abused. I would argue at that point, because honestly, people abuse albuterol to the point to where they have, rebound tachycardia because they overuse it. So I'm not 100% sold on that point, but it was in your book, so I'm going to let it ride. And then over-the-counter meds purchased without a prescription. So yeah, those are the three types. Make sure that you know those. And then we're going to get into the schedules, which you're also going to need to know what that looks like as well. All right, so regulations are written to better maintain a tracking system of controlled substances. There was an act of 1970 which kind of spearheaded this whole deal, which required them to put them into 5 brackets of schedules. The schedules are over there to your right. Hopefully you can see that okay. So what I would probably do if I were you is I would have a basic understanding of what those 5 schedules meant, and probably what med is most associated with that schedule. That's usually testable material either on your NCLEX, either on your HESI, either on your standardized test. That's fair game. So I would keep an eye on those, and once you have a generalized idea of that, then move along. All right, nice way of putting this slide. If you do stupid things and you take people's medication, eventually you are going to get caught. And I cannot wait for the day that I hear it if you are in fact caught for doing something that absolutely stupid. So, you have had your right served if you decide to take your patient's medication and take it for yourself, or just take it out of the Pyxis and go running for it thinking that that's going to be a thing. Guys, don't play games with medications. I mean, not even a Tylenol. Don't do it. Don't ever do it. You will get fined. You will go to jail. They do not take it lightly, and no offense, just because we are what we are, and we are one of the last, most honest, earnest methodologies and ideas of a good occupation with good, solid people is nursing. So they literally lay the hammer of dawn on you if you do something that's so stupid. Just out of practice of showing everybody else what's going to happen. So I would encourage you not to do those things. That's just my warning. Like that's all I got for this slide. And let's move on. What this slide is talking about is we have inventory systems with medications. We usually only get a single dose if it is a single dose syringe. PCA pump is the first thing I think of, and you do have to have it signed off and you have to have it checked every shift. And then you have to have those pumps cleared. And what that means is all of our numbers are cleared and we're starting back at zero, and you have to put it into the Epic charting or whatever charting system you have, things of that nature. There is a backup to the backup to the backup system to say this medication was given to this patient and it was only a singular dose. So, these types of controlled medications, if we have a patient that comes in with them, we will also have to clock them or make them take them home in an acute care setting. In an extended care setting or an LTA or LTAC setting, those medications, a lot of times they will pull from those meds, but they still have to have two nurses count, keep a sheet together, file the sheet, display, like it's a whole to do. So it's really hard nowadays to take medications, but it still happens because people are just ridiculous. Go back to the last slide if you need any further aforementioned comments. So let's just go to the next one. All right, so narcotics, they're always in a locked cabinet. It always, always, always. It's either going to be a Pyxis, an Omnicell, a locked entryway cabinet. Like there are 1,000 different ways we do this, but it's locked. You're not going to get to it very easily. They have to check the order, the dosage, make sure everything is kind of on point. A lot of times, if it's done manually, like we're pulling from a patient's medication because that's all that they have available, and we don't have it at the pharmacy, so we allow that medication. Like I said, you have to have two nurses sign off of it. It's a big to-do. So that's basically what all of this says is controlled meds. Again, we have 9,000 ways of keeping other people from getting them, keeping counts on them so that we can make sure people aren't just eating them like Tic Tacs. All right, so prescription meds, they're monitored for use. You have to have a prescription order. You can't just go snatching it out of a rando counter unless, of course, you're given the med in a hospital. And then we have our med rooms for that. But otherwise, prescription is something that says, hey, listen, this is a medication that is a clinically trialed medication that is a step grade above what we need from an over-the-counter use perspective. We have to use medications that are going to be a bit stronger. We need to make sure that we take into consideration older people, younger people. Those medications are going to hit them a lot different. The younger kiddos, you got to watch how much you give them. The older ones, the same. For what reason? Well, they like to respiratory depress, both of them, right? And a lot of reasons and a lot of factors, I would say that one is just as scary as the other, although pediatrics always scares me more. And then, of course, critically ill because they're immunosuppressed and they're exhausted, and a lot of times they can't move around, which is also going to increase their propensity or their ability to get the same type of respiratory depression. If you're not moving around, you're weakening your muscles in that area. So that's just part of it. So all of these guys are at an increased risk. So we have to keep that into consideration as well. Y'all, over-the-counter medications. Let's talk about this real quick. So, low risk for patient when it's taken as directed. That is accurate. When taken as directed. Another point of contingency that I find to be very important in this case is over-the-counter meds should be ordered by provider in the hospital setting. Here's why. I had a patient in neuroscience in neuro ICU. He was a 21-year-old patient who was legally blind nearly overnight, and nobody could figure out why. His scans were cool. It was a legit thing. We're all trying to figure it out. Nobody can. And all of a sudden, he, at 9 o'clock at night, looks over to his mom and goes, hey, can I have some of that Benadryl again? Like, I need it. I can't live without it. And I was like, wait, what? Wait, what? How much, huh? Come to find out, this kid has been taking Benadryl since the age of 16. which doesn't sound like a lot. However, let's talk about the dose. The average Benadryl is 25 milligrams, which is enough in itself to take every day. For how many years? Yeah. Do the math. Okay, great. They were taking, we started off at 25. By the time we were 18, we were up to 50 milligrams a day. Now we were up to three Benadryl a shot, as in, hey, give me 3 Benadryl so I can go to sleep. Hi. So come to find out, the Benadryl was the reason that we were losing our vision. Yeah, because we were going way overboard with that Benadryl. Yeah. So over-the-counter medications, when taken as directed, have a very low risk. However, can you really mess some things up? Yeah, you can. Is that a big problem when I'm giving my patient medications that might give them respiratory depression? Yeah. When you triple the dose of Benadryl on top of what I'm giving you, that's a big deal, which is why we do not allow over-the-counter medications within a hospital setting. We will always order them through the pharmacy, even if it's like something stupid like ibuprofen or Tylenol. And that's my story about that, and now you'll never forget it. All right, why are we talking about Canadian drug legislation? I have no idea, but we're going to talk about it regardless because it's in your book, so it might be a testable piece of material. The only thing I would probably pay attention to for this one is the 3 major classes of drugs under the FDA, or the Food and Drugs Act. Non-prescription drugs, prescription drugs, and restricted drugs are their 3 classes. Everything else, I don't really think we're going to see much of that at all, if ever. So, yep, that's it. All right, so ordering legal prescriptions. Legal prescription has to have the following information. So go ahead and look at all of these right now. Make sure that you understand that. If it is a verbal prescription, then you have to have the prescriber's NPI, which is their prescriber number, in addition to the prescriber's name, since you can't do a signature. So if I were you, I would take note of these items, because I could totally see me being the person that I am to give you a scenario in a question form that may or may not be like, hey, listen, which parts of this script are real and which parts of the script are not? As in, which one of these is appropriate and accurate and which one isn't? So again, fair game. Give it a look-see, memorize it, be done. All right, so we've got 4 types of drug orders. We've got standing orders. A classic example of a standing order is in the ICU. I always have a standing order set for my patient, specifically if they're intubated, if they are, trauma patients or head injury patients, anything specific. I'm going to have like an order set specifically for them, to anticipate needs that every type of patient like that is going to have. Emergency or stat orders is, you better give it to me hot and heavy. Matter of fact, I'm gonna meet you at your window, and you better go ahead and have it dosed, because I'm not even playing games with you. Like, that is a stat order. I better have that in my hand in the next 5 minutes. There is a single order or a one-time once order. And that's an order we usually get a lot of times if we have a patient who can't sleep. So we give them like a one-time melatonin for 9 o'clock at night just to see how it does. A lot of times we will use this if we have to do a PRN order, but we can't do the PRN yet because it's way too early. We will then do a single order for a patient. Common patient is a withdrawing patient. Maybe I can't give them Ativan for another half an hour, but that person is already showing me signs that they need it immediately, so they will give me like a one-time order for 0.5. And then what I can do is I can do an additional 1 milligram in that half an hour, which would give them a total of 1.5, and that fits their CEWA protocol and their scale. So there's ways to get around things as nurses that we have to do sometimes to keep our patient from seizing. And that's how we have the one-time once orders. That's how we do that. As needed, our PRN orders, of course, are, Q6, Q4, that type of deal, every 4 hours, every 6 hours. Those cannot be tampered with very much. There is a half-hour window for some hospitals, I've heard. Most hospitals do not give a half-hour window. So if you do it at 8 o'clock, and it's Q4, like you can only do it at noon. Don't try to pull that junk at 11:30. It's not going to go well for you. That's kind of how that works. And then like I said, there are some hospitals that are like 11:30. Meh, that's fine, no big deal. So just make sure that you understand your hospital protocol before you start playing those types of games. And it's actually part of your orientation, so you'll figure that out very quickly. And we'll go to the next slide. All right, so for the previous slide, I would know those different types of medications we just talked about. For this slide, I would say the most important piece of this slide is you must adhere to state in which you are practicing. There are a lot of nurses with a lot of different licenses in a lot of different states. I'm one of those people. So the licensure requirements are going to be different in Ohio than they are in, I don't know, New York or Virginia or Oregon, places like that. It's going to be completely different. California is another big one. It takes forever to get a license there because of all of the restrictions you have to go through and all of the red tape you have to go through. So usually the harder states to get a license in is because there's a lot more regulations and a lot more stuff going on. So you really have to bone up and make sure that you know what you're getting yourself into. And it's really hard to do that, and there's always updates. So you can only do the best you can do. And just make sure that we understand that you have to adhere to the regulations and requirements for the state that you are currently practicing in on that day. Because if you're a traveling nurse, like I used to do or like I do now, you will be multi-state, sometimes on 2 different jobs in 2 different days in the same week. It just is what it is, right? So let's go to the next slide. I feel like it goes without saying, we determine the responsibility for our actions, right? So all nurses have legal responsibility for everything they do, and the choices that we make dictates whether we continue to be a nurse. Do you get caught the first time? A lot of times, no. Do you get caught the 15th time? A lot of times, yeah. Sometimes you get caught before then. Sometimes you don't get caught for years, but when you do, oh buddy, they lay it down hard. I'm just letting you know, don't do anything dumb. Don't do anything to hurt somebody. Like, I know it's hard when you get that patient that's just cussing you out and calling you every name under the sun, and part of you just is like, I could just take an extra 5 minutes to get this pain med to them, right? Don't do it. Don't do it. Please don't. Just don't do it. Because when you do that, you open yourself up to a window of a whole bunch of hurt and hate that is unnecessary. And not only that, but you are literally casting shadows around you because you were allowing that type of whatever to come up in you. That anger, right? That angst, that animosity, right? That little bit of twinge that you get in the back of your neck where you're just like, man, just don't do it. All right? Just remember, you're not in the bed and they are, right? So let that attitude of gratitude keep moving you along, because again, the wrong person will perceive that action as a terrible, terrible thing. And quite honestly, it is kind of a terrible thing to do that to somebody. But specifically, that will come back to bite you in the tail if you get in the habit of doing stuff like that, because the PCU is always going to want to go a little bit further, because that's just the human condition. Just don't even get the habit of doing it. Otherwise, you'll be that person who just is just asking for trouble. And really, you kind of deserve it too. So again, always have the attitude of gratitude. Make sure that you are always responsible for your actions, and those actions have no moral turpitude around them, right? No shenanigans behind it. Next slide. All right, so here's the nursing process in order. I'm going to tell you, if it says 5 steps, memorize those steps. Assessment, diagnosis, planning, implementation, and evaluation. Again, assessment, diagnosis, planning, implementation, and evaluation. We like to call that ADPI. Remember ADPI? ADPI is usually always on your NCLEX. ADPI is usually on your HESI. ADPI is most definitely on your other testable sources throughout your entire program. Memorize AdPi. One more time, memorize AdPi. Okay, I'm done. I'm done. Nikola Tesla 3 times. Memorize AdPi. All right, for sure, I'm done. All right, in your book, we talk about a Cardex, and listen, I haven't heard about a Cardex in my entire life. I had to look up a Cardex. And then I had to go, man, I got to do a JPEG of this or something. Like I just gotta show them what it looks like. So that little thing up here in the corner, this little thing up in the right hand top corner, that's Cardex. Apparently, a Cardex is still used today. I again have never seen it in my life because, well, I might be a little bit spoiled, and I might have started off in step down neuro ICU in a level 1 trauma. So that's my journey. But I hear that other people's journeys include Cardexes, where we physically put orders down on a piece of paper and then like right over top of them when they get changed, or maybe right below it, but there's just papers everywhere. And I guess you staple them after the day is done and the patient's discharged, and then you file it. Like, for how long do you file? Like, oh my God. Okay, listen, this is a Cardex. It's a thing. It is not a legal document. Hey, that's great. It's a whole freaking mess of papers that aren't even legal documents. Why do we have these? I don't even understand where they come from. How long has this been a thing for? Since the dawn of time? When did we change it? Why are they still existing in this world? Okay, I'm done. I swear. Now let's talk about EMRs. Oh, EMRs. So an EMR is your best friend in the whole wide world, because we literally hit tab, enter, and then we just hit, T, enter, T, enter, T, enter, T, enter, 1, 2, 1, 2. And that's how we grade our patients, and that's how quickly we chart, because electronic medical records are the greatest thing of all time. Also, EMRs have what's called a brain a lot of times. So like Epic charting is noted for having a brain in some hospitals. And what that means is all of my pumps are primed to my computer. So that means if I give my person a bolus of fluid at 12 o'clock and I forgot to chart about it, it doesn't matter, because I'm just going to go hit clear pumps, and what it's going to do is send all of that information from that 12-hour shift over to my I's and O's charting, and then it calculates it for me. The clouds just parted. Life is peachy. There's a rainbow. Oh my God, double rainbow. What does it mean? Like, I'm telling you, I don't know what this Cardex deal is, but I wouldn't know what to do without an EMR that's like seriously grinding all of its life like Epic charting. So if you find a hospital that does have Epic charting, all you need to hear is Epic. Automatically cheer on the inside, because it's beautiful. And I don't understand this Cardex. So that's my knowledge base of Cardex. Read the bullet points. That's what we got out of the book, and then let's move on. So every day in the whole entire nursing world, I hear people who complain about something that somebody did wrong in the nursing setting, and they look at me like, could you believe it? I'm an STNA and this nurse did this. Can you believe it? And most of the times I'm like, yeah, I can. You just don't know any better because you're a nursing student that thinks you're never going to make a mistake in your entire daggone life. Here's the reality. You're going to screw up all of the time. Guys, let me just say it again. You are going to mess up all of the time. It's going to be tiny little stupid mistakes. Like you accidentally walk into the wrong patient's room with meds that you meant to give to the patient in the other room, but you just remembered that you still had him on the bathroom commode, and you were like, did my STNA get him up? That was a good STNA, I'm sure. Let me just check real quick. And you're about to go dip into the one patient's room to tell him you'll be right back, and then you walk right into that patient's room. That's how drug errors occur. It's little stupid things like that, only they're bigger, all right? So how do we do it during preparation? All right, cool. Names look sometimes identical, okay? I'm not even playing with you. Michael Smith, ready? And Michael this, okay? I know that sounds really weird, but when you're grabbing for two different patients that are literally one room away from each other, and one is this and one is Smith, it's a big problem, all right? So this happens easily. Number two, I'm preparing a medication and I forget to pop the top lock on the medication. So sometimes you got to squeeze a bag, and then you got to squeeze it a second time so that you could get that fluid into the next chamber. And then what that's going to do is that's going to shake up all your medication. Well, guess what? If you don't really pull off that tab and you don't shake it together, then you're only going to get half a dose of medication, or sometimes not at all. So that's how you do it that way. Bring in the drug to the patient. Don't pull for two patients at once. God, of all the dumb things to do when you're a novice nurse, don't pull for two patients. Never pull for two patients. Just don't do it. Have I pulled for two patients in my life? Yep, we all did during COVID. But do you pull for two patients ever, ever, ever when there is not an apocalyptic situation? Dear Lord, heaven, no, don't do it, because you almost always end up flipping pills here and there. Now listen, some people have this great bag system. Some people do fanny packs and they think they got it all figured out until they come to me frantic. And let me tell you, I don't care how good you are, it happens to everybody. Don't pull for two patients at once. There, I'm done. I'm not going to say it again. Don't pull for two patients. Don't flip and do it. It's going to go bad for you real quick. All right. Incorrect time. Again, PRN meds. This is a big one. And it's because a lot of traveling nurses do this. A lot of traveling nurses are like, it's half an hour before, half an hour after, because that's acute care hospitals. If you travel to one and then they throw you over to another one, that sister unit may not be down with that. So this is how this classically happens. So make sure when you get into the hospital, you ask the big questions. Where's the code cart? Where's the med room? Where is the supplies room? And what are your policies on charting? Like, is it Q4? Is it Q2? Is it Q1? What are the policies? Just run through them real quick. Boom, boom, boom. That's kind of how that works. All right, listen. High alert drugs and pinch. You better memorize this, right? Just as much as RuPaul says, you better work. And here's why. This is going to help you out for everything, all right? Potassium, we're going to talk so much about potassium and all of the things that are going to make your potassium go out of whack, because potassium is a really big deal. Insulin for sure. Narcotics, opioids, why? Because of respiratory depression, that's why. C is for chemotherapy drugs. That's a big one as well, right? Because we have to handle chemotherapy drugs completely different than we handle any other medication. And then H is for heparin, which is a big deal because, well, you run it too hot and, well, your patient's it's gonna be like running water coming out of them if something happens to them. And sometimes we have to do it that way because they're gonna clot and die if we don't. So you gotta know what that looks like, and just memorize the entire acronym. All right, black box warnings. You cannot play with a black box warning. Why? Because those meds could quite literally kill you. All right, so you have to check these med labels to make sure that your patient is not experiencing any of those symptoms. And if they are, get them off of it as fast as you physically can and get all the labs to make sure that they are not going through a toxicity of that medication or going through a toxic phase, because this is going to go really bad or really quick if they continue this medication. All right, so that's a black box designation and why it's such a big deal. All right, the dreaded med rec. Everybody hates to do a med rec, but here's the deal. Med recs are necessary. Why? Because honestly, a lot of times hospitals are the only ones that have a good med rec. Like, I've seen primary care facilities that when I go into them, they're like, yeah, are you still taking da-da-da medication? And I'm like, I've been taking that medication in 10 years. What are you talking about? Where did you even get that? Where did that come from? All right, so as nurses, when we get patients, it's our responsibility to do a med rec, and that is to look to see if anyone's medications look out of whack, or to make sure that they don't have any that they aren't taking, that they have some that they are taking, that they have some from this pharmacy that they take. Like, it's our job to just basically be like, all right, now that we're like here, you need to tell me everything you take from every daggone place ever. And if you can't get your patient to give you all that information, or if you suspect they're missing something, just call the pharmacy. Be like, hey, let me verify your pharmacy real quick, so when I get all your prescriptions to you, we know where to take it. And they're like, oh, yeah, get it here. And then you just call them real quick and you're like, hey, can you tell me what their meds are? Like, they're currently in the hospital. And they'll rattle them off for you. And they're like, yeah, no problem, da-da-da-da-da, just so we make sure we got all this clarified. And that is going to be your best bet for med reconciliation about 20% of the time. So that's my veteran hack, is just call the pharmacy. Find out who the pharmacy is. Always ask the pharmacy before you get into the meds. So that way, they could be drummed up that, all right, prescriptions are going to go here. And then if they get into the uncomfortable talk about what meds and how much meds, at that point, you already got the pharmacy, so you can get the info so they don't shut you down and don't let you know. That's the hack, just in case you're wondering. Always ask pharmacy first, then start the med rec, and then call your pharmacist if you suspect anything doesn't make sense. All right, so protection of healthcare workers. Listen, if you do not have the right equipment, you do not need to be lifting 500-pound people. You think I'm joking. I've had people who expected me to move them because they weren't able to move, and they were, 500-600 pounds. Sometimes we have to work in those type of units. The problem is when you don't have Hoyer lifts to accommodate that, and they have congestive heart failure, you can't stick them in a reverse Trendelenburg position and they can keep it because there's too much weight on their chest. They won't be able to breathe for long enough to be able to scooch themselves up. So again, you run into the problem of take care of your patient or break your back. Nurses notoriously have lower back problems for this reason, and because they don't use their bed to their advantage. Always move your bed, never bend down to your bed. Your bed has switches like a 1968 Impala that's been done right. And there's a reason for it, because you need to use them so that you can save your back. Please, for the love of Pete, cheese, and all that's good and holy, do it. So make sure that if you don't have those Hoyer lifts, that you have a lift team and that you are like, look, I'm not going to do it. Well, how do I get those items? Well, if you have broken machine equipment, then you need to notify it to your manager. If your manager can't fix it, then it needs to go up the chain real quick. And if that doesn't happen, you need to make a quick call to the company and that head, because here's the deal. You're not going to mess up your back and that be the reason that you can't move for the last 20 years of your life, because you decided to help out somebody, but nobody decided to help you out. All right. I need for you to understand that your body matters more in this situation than anything else, because you are not going to continue to be a good nurse if you cannot move like you could when you first started this gig. And I'm telling you, after 10 years of doing it right, I am just as good as I was the day I started, if not even better, right? Because I got my knowledge base. But a lot of nurses that have been in the gate as long as I have are down with back problems. So they've had to, jump on to different jobs, or maybe jump on to a more, non-clinical role, more like a management role, because they did hurt themselves. Don't let it be you. Okay, if you don't have what you need, you should not be doing that task. And if you don't have what you need, you should be clowning on somebody to go get it, because everybody should be a zero lift zone. And if you're not a zero lift, then you should have a lift team of some sorts, or you should have the equipment you need to be able to do that. Period, point, paragraph. All right, I'm going to go ahead and finish this up. I am going to post it, and then I'm going to start working on your test. It's going to be okay. Take a deep breath. Pay attention to the things we've talked about, and then I am going to expand on chapter 3 on what we need to focus on specific to that, and then we will work on other overviews for this other material for this coming up week.